She's a superstar. So we would like to welcome the three keynotes to also come and sit at the top here with the guest of honor, that is Professor Ben, Professor Petra, and Raso, as they get ready to give their keynotes. Karibuni. There are three chairs, you're all fit, it's fine. Karibu. Okay, so the first keynote we have is Professor Ben Wachira. Professor Ben Wachira is an assistant professor of emergency medicine with a deep commitment to improve the emergency care in Kenya. He currently serves as an emergency medicine program director at the Aga Khan University in Nairobi. There he trains future EM providers and plays a really crucial role in shaping the direction of EM in Kenya. You should know that Professor Ben is a founder and ED of the Emergency Medicine Association of Kenya, and is an organization just like EMAT that focuses on capacity building, knowledge development, advocacy for EM in Kenya, and research strengthening in the whole EM system in Kenya. Dr. Wachira, or rather Professor Wachira, is a past president of the African Federation of Emergency Medicine, that's AFEM. Where he worked tirelessly to advance emergency care through African continent. He's a prolific writer and has published widely in EM care all over the world. His research had led significant improvement in EM care, not only in Kenya, but also in Africa. Karibu.
Thank you. Morning, everyone. I don't like podiums, but I guess there's no roaming mic. How are you? Bariza asubuhi. Fresh, welcome. Good. Good to be in Tanzania. Congratulations to Peter and his team for getting this together. As Peter always asks, do you have a presentation? I was like, yes, we'll wing it. Don't worry. All right, so my topic today is about policies, and something I'm very passionate about, and I'll explain why, and give you a bit of background of what I do, what I've been doing, and why you should be doing the same. So maybe I will just start by asking healthcare providers, put your hands up. Straight up, be proud. All right. Keep your hands up, calm down, keep your hands up. Now, how many of you trust the hospital you work in will save your life if you ever collapsed on the corridors? Keep your hand up. If you trust your life saved by the hospital you work in, yes. Those ones working in Africa, Americans, please come on. Anyone out of Africa, yes. How many hands are left up? I'm only seeing the hands significantly disappeared. All right. So, and a lot of you potentially are emergency people, and I'm sure you can resuscitate a rock to start talking and walking. You're really good at your job, but unfortunately, you can't resuscitate yourself. All right, and so you provide a service you will not get when you need it. Okay. Other question I'll ask: if someone in your household, let me leave it that way, collapse right now, would their life be saved? Okay. If someone was choking in your house, do you think their lives would be saved? Will there be an ambulance? Is there an EMS number? Okay? You can save their lives. You are standing there. But right now, since you are in Grand Melia, who would be saving their lives? Okay? So it's a question I asked myself many years ago. And I'll be truth and honest. I just left ICU a couple of weeks ago. I was in ICU for 3 weeks. And I did collapse in my own hospital. And they did save my life. Okay? So testament to the work we've been doing to build the systems. So a lot of us as healthcare providers are very good at what we do. We train hard. We become the best, okay? We can resuscitate anything that walks through the door. But we are very reluctant to engage in policy development, very reluctant to get into administration, and are only happy to just deal with the patient in front of us, okay? And which is a big problem. And I think a lot of the EM development on the continent was driven by partners coming in from the West. But the West has systems, okay? The West has systems where then now the focus is just treat the patient in front of you. The rest of the system works, okay? But in our setting, unfortunately, the patient in front of you is the only one who will benefit from your care. The patient next to them will probably die because you're busy focusing on this one, and there's no one to treat that next patient. And we've done a lot of focusing on EM training development, which is great, and have developed healthcare providers like you, which is great. But unfortunately have not moved the needle in terms of are we saving lives as a healthcare system in total. And these were the challenges I faced when I came back to Kenya in 2012 after my training in South Africa. And I remember having a chat with my director and telling them, well, I could sit and see patients in cubicles. That's great, okay? I mean, and each patient I see will benefit from my care. Fantastic. But what about the rest, okay? Who will take care of the rest that I am not seeing? How will their lives be saved? And the discussion at that point was, let's focus on building the emergency healthcare system within the hospital and less on how many patients Benjamin is seeing, okay? And that's what we did, and I've been doing for the many years I've worked at the Aga Khan. Bosses have come and gone and keep asking, what exactly do you do? You're a doctor, you don't see patients. Yes, I don't see patients directly. My job is to make sure that every patient who comes to the emergency department gets the best care possible and their lives is saved where we can. And that's the objective. But how have we done this? Yes, there's a training part of it, okay? But more importantly, because healthcare providers come and go even within the departmental level, but what are the hospital, do you have a hospital, how many of you have a hospital policy on emergency care? I see no hands. How many of you have a hospital policy on resuscitation? I see no hands. So again, the assumption is people know what to do, okay? But unless it's documented, my friends, no one knows nothing, okay? You have all the knowledge in your head, but unfortunately, you're the only one who possesses this knowledge, okay? At the Aga Khan, we've developed significant systems and documented every single process that should you collapse, even on the streets outside, well, not outside Aga Khan, in the car park, there's a process for that. There's a process that there's a whole team that will respond to you, and this is documented, put in policy, tested, trained, and continuously improved on to make sure that the system never fails, okay? So building that system, documenting that system, ensuring everyone understands that system, and everyone means even the cleaner at Aga Khan knows if someone collapses, this is what I need to do, okay? And this has gone through by building the policy. Yes, a few people are trained in resuscitation. The cleaner may not be that good at CPR, we try, but sometimes not that good. But he knows exactly what to do to make sure that this patient will get the care within the time period. But the important part of this, beyond building the system and documenting the system, is the hospital appreciating the role emergency care plays. Because everyone thinks emergency care is just the emergency department. But across the entire hospital, patients do collapse, patients need emergency care. And if you've seen, sorry for ward people, if you've seen ward people try to resuscitate a patient, siko ubaya, yes, it's normally quite dramatic. But if you're in the hospital, why do you want you have a whole emergency department and a whole emergency team. So why are you giving people pressure upstairs to resuscitate patients? They really do need to be resuscitating, and there's help available. So by developing, working, and this is not you sitting and writing the policy, well, you'll sit and write it, but then working with the entire hospital administration, working with everyone to these policies, ensures that the hospital recognizes the role emergency care plays, and this expands from individual patient collapse to disaster management and mass casualty incident management within the hospital. The hospital allocates funding. Money is important. Do never ever lie to yourself. Allocates funding for all these processes, the staff training, then there's justification to train more staff, whether it's on mass casualty improvement, management, whether it's staff training, individual staff training, because this is all enshrined within the hospital policies and procedures to make sure that at the end of the day, we are safeguarding the lives of all the patients, not just the ones in the emergency department, all the patients coming through the hospital. Similarly, of course, you always have the fights between the emergency department and all admitting clinicians. It's a constant. You will always be fighting. Please come see your patients. Please come take your patients. Yes. But again, by documenting the process, sitting in meetings, having to explain to them exactly what you do, putting every single process. We have I think it's like a whole 50-page manual for every staff who walks into the emergency department. There is a step-by-step guide of orientating them into the emergency department, all the procedures, processes. They have tons of administrative exams they have to do before they are allowed to see a patient. And again, this goes through from the documentation processes. And you start with one document, you keep building up. So don't think you'll ever do this all at a time. But you'll do one at a time, and you build up to we have a whole A&E handbook, which every staff has to go through. And we keep building up on it to make sure that every single person in the department is well oriented on how to provide emergency care. And note, none of these things I'm talking about are about the clinical protocol for managing heart attacks. No. Those ones are what you do in training, and those ones, they're in an algorithm somewhere. We developed actually a lot of those algorithms. But it's more about the administrative parts that we ignore, the policy parts that we ignore, the understanding of the processes and procedures, because the A&E the emergency department is quite a chaotic place to be. And getting a staff off the streets and just putting them there to work there is a disservice to the staff and to your team and to your patients. So making sure that you have a proper orientation process is important. So that's on the documentation and policy development at hospital level. And some of the policies you can look at developing things like a triage policy. For example, every patient walking into the hospital must be seen by a healthcare provider within 5 minutes of arrival into the department. So what's your triage policy, patient reception policy? What's your policy on just patient care? We have a turnaround time to say no patient should be in the department more than 4 hours, for example. They need to be out of the department and admitted or wherever they're going. What's the policy on patient care within the department? What's your policy on resuscitation within the department? What's your policy on resuscitation for the hospital? What's your policy on mass casualty management? What's the procedure for this? What's your, let me see which other, we have so many of those policies, yes. What's your policy on infectious disease control within the department? What's your policy? Now we actually we've gone now to the depth of specific, what we call clinical protocols, which still are also in policy for heart attacks, strokes, to make sure that by the time you get in, within, at least for a heart attack, you should be in the cath lab within 20 minutes of an ECG being done. That has to be in policy, that has to be protocol developed, and training has to happen. So there's a lot of these policies, and you develop them as you go along and understand where are your gaps in your systems. And the objective again is, should you collapse in your hospital, should you collapse in your department, they should be able to save your lives. You should be able to get the same care you offer your patients at that level. So that's the hospital perspective. So let me talk now more on country level perspective. So I came back, so my research project, which I did around 2010, I went around the country and spent 24 hours sitting in at least, 16 major public emergency centers across the country, just to observe the care that was being provided, or the lack of, and understand how emergency care was being practiced in a country which did not have emergency care established at that point in any format at all. And it was shocking, okay? Having left a system, well, I was training in a system where to die was made it very hard. Like, if you died, your maker was calling you, but if your maker was not calling you, the system took care of you and you left the hospital and you survived. And from that experience, I realized that, yes, it's good to develop and train individuals, but if we're not gonna fix the system, then everything will remain broken and we will not achieve what emergency care is supposed to achieve, which is save lives. And the other part of it that people need to appreciate, and we all need to appreciate, is emergency medicine and emergency care is a system. It's not an individual, it's not a handful of people, it's a system. Patients do not get sick when they show up at your bedside. Patients started getting sick in their house, okay? They started feeling unwell. There was a lot of calculation of, can I go to hospital? Am I afforded the time? Will I be fired from my job? Do I have money to go to hospital? Those are decisions being made before your patient showed up at your bedside. When they finally decided they're too sick to survive or to stay in the house, then the next decision was, how am I getting to hospital? Do I walk? Can I walk? Do I take a boda? Can I afford? Can I survive? Do I call an ambulance? Can I afford? How much will the ambulance cost? Is there an ambulance? So these were factors being decided as this person is still sick and trying to get to the hospital. Eventually, they find a means of way to get to the hospital. Whether you've provided one or not, they will eventually get to the hospital. They get to the hospital. They have to choose, which hospital am I going to? Can I afford the hospital am I going to? Do I even know the right hospital? Most will just say, let me go to the nearest hospital. So here you are having a heart attack and you're in a health center in the middle of nowhere. Is that hospital going to save your life? They don't know any better, so they will just go to the nearest hospital. So they'll go to the hospital A, they know, B, that's nearest to them, C, they can afford, okay? And D, their friends have told them that's the best place to go. So these are all individual decisions that patients have to make in our setting before they finally show up at your bedside. And I'm not even going to talk about the reception process within the hospital, which is as dramatic as it gets. But so by the time you're seeing a patient and asking them, where is your patient? This patient has been juggling decision making from way many hours before, plus minus. Compared to a system where, and this I'll use the 911 system in the US, where the only decision I have to make, okay, this is a bit tricky in even in the US, but is, do I know how to call 911? Once I make the call to 911, I don't have to think about anything else. This is assuming you have money. America is also having problems. I'll dial 911 and just sit. An ambulance will show up. They will start providing care for me in my house. They will decide where to take me. I don't even have to think whether I have money or not, at that point, assumingly. I will be taken to a hospital, I'll be received, and they will get, as in, you do not have to think at all in an American system, or even the UK system, or the US, or European systems. The only decision you need to make is dial 911. That's it. Everything else will be catered for you to the end, yes, and then maybe billing will show up a bit later. So it's different in our continent. Anyway, back to what I was saying. So I realized, yes, we need to build a system. We need to build an emergency care system at country level, and we need to build a 911 system in a Kenyan system. And in that phase, so this was around 2012 or so, that phase is when we started thinking, or I started thinking with a few friends, of setting up the Emergency Medicine Kenya Foundation. Initially, we were excited about just training healthcare providers. And to be honest, our mission and vision has morphed into a more holistically, which is what I'll explain at the end, what we do now. But we started talking about emergency medicine and looking at how do we build the emergency healthcare system. Yes, there are already healthcare workers working in emergency centers. So our initial phase was, let's educate them, let's provide them with the protocols and the tools, let's make them understand emergency medicine and how to provide emergency care. You do not need to be an emergency physician to provide emergency care. You need to be a healthcare provider holding a good protocol and understanding what you need to do. That's what you need to be to save a life. And so we started with that phase of really trying to educate people, but it being a new field, the emergency medicine was not even recognized as a specialty in Kenya at that point. It being a new field, we started being pushed to do more and more and more, and started getting into government space, where we started being asked by government to start talking about, start doing something to fix the system. And so a few things happened. So in 2010, this was, I guess, just before I came back, the Constitution of Kenya was changed. And in that Constitution, the two rights that every Kenyan was entitled to was the right to emergency medical treatment and the right to reproductive health. And that was just left as that, okay? They didn't define how that was going to be provided. Nothing else was done beyond that. But so when I came back in 2012, we started working with the Ministry of Health to start looking at how are we going to do this? How are we going to provide the emergency treatment? And I can tell you, when you start working with policymakers, there are many things that people need to understand, and this is lessons I've learned also, is many people think making is hard. Yes, it is hard. Okay, that's the truth. Many people, I don't know that there are many, how many people believe your government is not working? You can just smile, because just in case you're being noted. But the truth is, government works. And I know, because I spend my days working a lot with. So Kenya was devolved into a national government and 47 different county governments. So I work with 48 governments. And it's painful as it is, government works. It just doesn't work the way we think it should be working. It doesn't work the way corporate works, private works. And there's a lot of learning that one needs to do to understand how government works. And it's a painful process, but once you have that understanding and you sit and listen to the policymakers and to the politicians and have regular dialogue with these people, they're human like you. They also want their lives to be saved. And many politicians have collapsed and died. And I will always remind them, if you collapse in your office right now as a Minister of Health in your county, who is coming to save you? Once you have that discussion, now you sit down and start really thinking about it and developing. And the other part of it is now working to develop within the context of your environment. Yes, I'd love to have a 911 system operating in Kenya. But right now, some counties barely have an ambulance. So we have to start from somewhere. So there are multiple, if you've ever seen the WHO emergency care system framework, there are multiple components that need to be developed. And you start working, chipping up slowly by slowly as you develop each of the systems, working hand in hand with the policymakers, but documenting, again, politicians change per hour. Okay, they get fired every other day, there's an election and the whole government leaves. So the key part of it is writing this up as policies, and I'll explain the benefits of policies, both at national level and county level, and really documenting all this process as you go along, having the county guys sign it off, because once something is signed off as policy, it doesn't matter who is in that office, it is policy, and that's what gets then implemented, even in its most rudimentary form, but have it documented. These policies normally are written to be improved year after year after year. So as we review the policy, we can move to the next level and the next level. But do not write things also in those policies that are unachievable. Start with what is there, what they can do, and then slowly move on to start being aspirational based on how things are developing. And so Constitution 2010 has the emergency care and reproductive health. And then there was a lag, okay? So we pushed and pushed and pushed, having tons of meetings, yes. Please be prepared to have multiple meetings with government. This is not it's not an email or one Zoom call. No. You will meet, and you will meet. And so we said from 2012, we're working on the national policy, on Kenya Emergency Medical Care Policy, and we worked, having tons of meetings, and trying to get everyone on board, ministry, and the many factors, this treasury, and all the other people that need to be involved. And the good thing, so as we were working on this, we were also involved in the Health Act 2017. So there was a change in the Health Act, in the Constitution 2017, which further went ahead then to demystify more about what kind of emergency care is required. And they put in clauses such as, if you're a healthcare provider and you refuse to provide emergency care, then you're medically liable. And if you're a hospital and refuse to provide emergency medical care, then you're liable up to Kenya shillings 3 million, which is, I don't know, $30,000 or something. Yes. And so there was further definitions about the liabilities of not providing emergency care. But there are still gaps in what is emergency care. It is never, we all know surgery, we all know pediatrics, we all know whatever other specialties there, but there was no specialty of emergency medicine. But this slowly gets, again, through a lot of lobbying, the Kenya Medical Council in 2017 also, I think, recognized emergency medicine as a specialty. Even if there are no training programs in the country, they did put in their list of specialties that emergency medicine is a specialty. And then that, of course, opened the doors for any emergency trained person to be recognized as a specialist in the country. There are pros and cons of this. But again, back to legislation, back to documentation, back to policy. So the Kenya Emergency Medical Care Policy 2020-2030 finally saw the light of day in August 7th, 2021. We finally launched with the Ministry of Health, and this was the first ever policy in Kenya, but even across the continent. I think it was one of the first. The many countries have a policy on emergency medical care. So it's the first policy that really well defined what is. This was backed on the basis of the WHO Emergency Medical Care System framework, but detailed what we're talking about emergency care. So Constitution of Kenya 2010 talks about emergency care. Health Act 2017 talks about emergency care, but the policy now by the Ministry of Health then now specifically went into detail about what's the scope of emergency care, what does emergency medical care entail, what are the components, how is this going to be done, and within the same, there was a strategy done, Kenya Emergency Medical Care Strategy 2020-2025, policy documents approved by the government, launched, that went into details and put money, budgetary allocations to this process. This was great. This was significant progress to what we were working, and that opened a lot of communication both at national level and at county government level. And just maybe to explain how our system works. So national's role is to write policies. They do not provide healthcare at all at national level. Healthcare provision is a responsibility of the county governments. So while the national has done its job, now we have a policy. So you can't blame government for not working, okay? But it's not their responsibility to implement that policy. It's not their responsibility to make sure that emergency care gets to the common wananchi. And so from that point in 2021, we now started as an organization to work with the county governments, because now we need to work with all these 47 county governments to take the national policy, adapt it for the county government level, have them approve it, have them budget for it, and be able then to have county government emergency medical care plans. So far we've worked, since 2021, as I said, it's a process. We've worked with, I think we're almost at 20 county governments, and have had 10 are finally approved. The others are in the different stages of approval. And as I said, with government, it takes time, and there are too many changes in government. But what we've learned again through the process is, even at every county government level, is every county is different. Every county has different challenges. So it's not a copy-paste kind of system. But more importantly is the process of how money gets allocated for specific services at county government level. Without any policy, no one is allocating money for nothing. Okay, government doesn't allocate. It's not just drop money here. Okay, government only allocates money to documented processes and documented policies. So if a policy does not exist, there is no budgetary allocation to that process. So when you keep asking, where is the government not investing in emergency care? Government is a body. If he has no reference documentation, then there's no money that's going to be allocated. So that's why your systems are not developing. And so we realized that the importance of us working with the county government to develop these policies, to put budgets for these policies, and having these policies launched has led to significant, really growth in emergency care systems at county government level. The helps the county government to, number one, understand which are the emergency care centers and start allocating training budgets and emergency department development budgets. Number two, a lot of dispatch centers now are being set up in many of the county governments purely because there's a policy that says we need to set up county emergency dispatch centers at emergency centers. Ambulance services are being developed at county level. But even for that now, we actually have to work again with the county to develop a specific policy. Everything needs policy. If it's not documented, it's hearsay, okay? And as soon as the current government leaves, the new one comes and they're like, you did what? There's no, whether that's one other thing you really learn from government. There's no handover. When an office bearer is kicked out of office, they leave. There's no handover process in many government processes. So the only documentation that will exist is a policy that you worked on. And in many instances, for example, we'll have one county government come and leave. Then the next county government comes and they're like, what policy? We're like, here is your policy on we're giving them back their policy, and then there's a further discussions and we move on in development. But these policies then help us to strategically look at how are we training, how are we developing the emergency departments, how are we developing the ambulance services at county government level, how are we training the providers to make sure they can provide that emergency care and build on that, okay? And so that is what we've been doing. So the Emergency Medicine Kenya Foundation essentially works with governments and emergency healthcare providers to strengthen the emergency healthcare systems in Kenya and save lives across the country. And my call to all of you again is to think about it when you go back. Yes, you're a great emergency care provider. You're the best of the best. But again, how much influence do you have in terms of how you develop your systems? And also, will your life be saved where you work, in your neighborhood, in your country? And I always say, my job mainly involves building the entire emergency healthcare system in the country to make sure that no matter where I am across the country, even if I collapse, not just in my hospital, at least they'll keep me alive long enough to get me back to my hospital. That's my hope, okay? To make sure, maybe they may not see me, but at least they'll keep me alive long enough to get me back to my hospital, for maybe then they'll save my lives. But it's something that we always need also, it's something that we all need to think as healthcare providers and start getting engaged in policy development at facility level, regional level, country level, because that's the only way we're going to end up with a 911 system similar to what our 112 system, and essentially emergency healthcare systems that save lives in the country. That's it. I don't know how much time I have. Happy to take questions.